Hi, and welcome to I Have a Client Who, Pathology Conversations with Ruth Werner, the podcast where I will discuss your real-life stories about clients with conditions that are perplexing or confusing. I'm Ruth Werner, author of A Massage Therapist's Guide to Pathology, and I have spent decades studying, writing about, and teaching about where massage therapy intersects with diseases and conditions that might limit our clients' health. We almost always have something good to offer, even with our most challenged clients, but we need to figure out a way to do that safely, effectively, and within our scope of practice. And sometimes, as we have all learned, that is harder than it looks. Dear listeners, I've got a really challenging story today, so let's not linger. Let's get right to it. Here's the letter from our contributor. I have a client who's been experiencing severe neck and head pain since 2017. They were getting a kidney transplant and woke up too early from the surgery. This is how they described it to me. They were still intubated, their head was back, neck extended, and the tube was ripped violently out of their throat. Ever since that day, they've been having intractable neck pain, accompanied by migraine-like headaches. They said the pain in their neck is located at the top 3 vertebrae. They've had imaging done with no visible injuries noted. They've tried physical therapy, acupuncture, TENS unit, although the way they described it shocking them, I think it might have been used incorrectly. Also cortisone shots, heating pad, and other conservative treatments that I don't remember. The only thing that brings the pain down a little bit is acetaminophen followed by a hot shower, but then it comes right back. They had a head CT on April 20th, 2025. Obnoxiously, if you don't click the encounter, it just says no acute intracranial findings. But if you click on it, you see that it also says nonspecific calcifications of the falx and tentorium, additional nonspecific calcifications along the scalp vasculature, and anterior scleral and choroidal surfaces of the globes, as well as small focus in the posterior aspect of the left globe. This patient does have hypercalcemia related to their kidney transplant and has calcium deposits in their lungs as well. When I searched the internet about the CAT scan, the NIH said calcifications in the scalp vasculature can be associated with headaches and other neurological problems. In gently palpating their scalp, I did find tiny hard places under the skin, especially above the ears. Yesterday, in our first meeting, I thought maybe guided meditation, ideally hypnosis or some form of somatic trauma therapy, but I have no training in that. That might be possibly helpful. So I did try a sort of EFT-style guided meditation while doing some very gentle tapping and some simple holding. It did not affect the pain, but they did say it was relaxing. I'm going to see them again today, and I just wish I knew what I can do best for them. Do you have any thoughts? Well, yes. Yes, I do have some thoughts. First, yikes. It sounds horrible to wake up in the middle of a difficult surgery and have your breathing tube ripped out. It makes my throat hurt just to think of it. Secondly, yikes. Intractable migraines and neck pain since 2017, that's a burden. And thirdly, thank you. Thank you, contributor, for bringing this story to us. Thank you for using your skills to try to make things better for this person who has so many challenges. Okay, we're going to approach this from a position of curious ignorance, starting with some things that happen with end-stage renal failure and calcifications and what a CT scan is and what those CT test results might actually mean. And finally, where all of this leaves our client and practitioner. You ready? Good? Let's go. A short synopsis of end-stage renal failure. You know, I hope, that you have about twice as much kidney function as you really need, right? And maybe you know that kidney function and cardiovascular function are all tied up together in many, many ways. Hydraulically, in that how much fluid we hold in us is a reflection of kidney function, and that impacts our blood pressure. Chemically, because the chemicals, especially electrolytes, that the kidneys leave or extract in our bloodstream affect the way the heart works, and in a whole heap of other ways too. When a person loses kidney function over time, they go through stages of kidney or renal failure, and this is measured in their glomerular filtration rate. And I'd love to describe that to you, but it's not really our focus right now. But I just really love to say the word glomerular, so I'll do it again. As the glomerular filtration rate, that's a reflection of how well the kidneys are working, as that falls, the progression through renal failure proceeds. By the time someone's in about a tenth of their normal GFR, they are probably on dialysis and on a waiting list for a new kidney. Now, at this point, I could go off on a whole riff about that transplant list and the number of people waiting versus the number of surgeries done and how that list reflects systemic racism in American healthcare, but I digress. Problems with GFR are not the only things that go wrong in renal failure. Chemical disruptions can ripple through a variety of systems. One of those disruptions is called vascular calcification, and it is exactly what that sounds like: the deposition of calcium in blood vessels throughout the body. This makes blood vessels stiffer, and it bumps up the risk for hypertension and heart attack and stroke and more, and it is a common complication of renal disease. And as we know, this client has already been identified with hypercalcemia, too much calcium in their bloodstream. The exact sequelae from renal failure to calcium deposits in the arteries, not always clearly understood, but there is a definite correlation. Can this kind of calcification also happen in the brain? It can. It's usually limited to the intracranial arteries, but what was described to us was a little different. The CT scan found calcium deposits in various places on and around the cranium, the falx, the tentorium. Right, so I only have vague memories of these structures, and I'm going to pretend that you have vague memories of them too. The falx cerebri is a sickle-shaped vertical sort of blade of fascia that splits the brain into left and right hemispheres. It comes down from the top of the cranium. It's actually an extension of the dura mater. Literally, that means tough mother, which is the most superficial layer of the meninges. The tentorium cerebelli is similar, but in a different location. The tentorium, called that because somebody thought it looked like a tent, is on the horizontal plane at the back of the cranium, and it forms a sort of wall between the cerebrum on top and lower structures, the cerebellum and the brainstem. If either of these structures is weakened and tissue bulges through them, we call that a cerebral hernia. So our client had other calcium deposit findings too, along the surfaces of the globes, that's eyeballs to you and me, and in the scalp vasculature. Okay, hold on to that. We'll come back to that in a minute. The client in today's story was one of the lucky ones, at least as far as their kidney disease goes. They found a donor with a good tissue match. They were healthy enough for a surgery that is this complex. And that is often no longer true of people who have been on the waiting list for a while. We don't know anything else about them: how old they are, how long they'd had kidney disease, if it was related to diabetes or hypertension or something else, what their cardiovascular health is like, if they'd been on dialysis and for how long. Some of that information might be useful, but we will forge ahead without it for now. We do know they were in end-stage renal disease and they got a new kidney, but they woke up mid-surgery and now they have this terrible neck and head pain that does not respond to treatment. Waking up mid-surgery is horrific, of course, and it can result in both physical and psychiatric trauma. And of course, the dividing line between those two experiences is fuzzy at best. It doesn't happen very often, thank goodness. I read that it happens about 0.13%, or between 1 and 2 people in every 1,000 surgeries. And it doesn't always lead to things like having the breathing tube ripped out of your throat. Some people describe being awake and aware, terrified, but still anesthetized in that surgical process, although the process itself isn't painful. Others experience excruciating pain. Not surprisingly, many people are subject to symptoms of PTSD following this kind of an event. But this is the point where I get a little discombobulated about this client, because they have been in pain ever since their surgery in 2017. So they did a CT scan in 2025 to look for reasons why. That's 6 years later. Let's talk about that CT scan. CT stands for computed tomography. It's a fancy 3D X-ray that captures lots of different types of tissues much more clearly than traditional X-rays. And the CT scan interpretation was this: no acute intracranial findings. But the detailed reading says this: nonspecific calcifications of the falx and the tentorium, additional nonspecific calcifications along the scalp vasculature and anterior scleral and choroidal surfaces of the globes, as well as small focus in the posterior aspect of the left globe. Well, that sounds alarming. So I looked up what this kind of finding actually means, and I'm very sort of happy to say that these changes are probably not alarming. They're very common with age, sometimes but not always connected to kidney disease, and they don't seem to be connected to this person's experience of pain. As a person who lives with a chronic condition, a persistent cough in my case, and who has undergone lots and lots and lots of testing to figure out what it is and what I may be able to do about it, only to be told, "Congratulations, Mrs. Warner, there's nothing wrong with you," I can tell you that this kind of finding is fabulously frustrating. But here's the thing. This pain for this client started right after their surgery. I can promise that those calcium deposits that the CT scan found, they did not arise overnight. If they are a factor in this client's pain, then they're not necessarily connected to the surgery, but the pain started right after the surgery. And so what do we do with that information? So did I just say that there's no cause for this person's pain, so they're not really in pain? No, I did not. But imaging techniques, even ones as advanced as computed tomography scans of the brain, have a not great track record for identifying the cause of someone's chronic pain, and I will suggest that this may be the case here. Our contributors started their massage session strategies with some low-impact interventions, holds and tapping and a sort of guided meditation to see if they can maybe move the needle a little bit. But besides inducing a state of relaxation, which is not nothing, they did not achieve what they were hoping for. And so they asked, do I have ideas for what to try next? Oh gosh, sure. I have lots of ideas about how I want to hold this person's head and soothe their neck. But here's the thing. I'm not in practice, and I haven't been in practice for a really long time. You, contributor, you, listeners, know so much more about caring touch and how to be with this client than I do. It seems to me from this description that this client needs presence and curiosity and someone who's willing to work with them as opposed to on them to seek solutions. Maybe it's craniosacral work. Maybe it's something with hot and cold to address migraines. Maybe it's breath work, or looking for where in their body they hold on to excess tension that might respond well to massage. Maybe it's another try with the TENS unit to be sure that it's being used correctly, and that might provide some relief. This whole story kind of breaks my heart, but it's not unusual. It is so often the case with people who live in chronic pain that no specific trigger is responsible, at least not anymore. What's probably happened here is what we call central sensitization, chemical and physical changes in the central nervous system that set up this person to experience pain responses. Central sensitization can be really, really hard to undo. It takes patience and support and addressing the whole person, not just the calcifications in their scalp vasculature, but the sense of self-efficacy and control that they feel or don't feel that they have in their life. In a situation like this, massage therapy can only be one part of what must be a whole person, biopsychosocial approach to pain management and trauma healing. I do truly hope that this massage practitioner and their client can work together to get some relief. It's probably going to be hit and miss. But I want to emphasize this. The very act of trying, of having hope for some improvement, of feeling empowered, all of that is part of the healing process too.